I now have the pleasure to invite Professor Rose Leke to deliver the first of two keynote addresses. Professor Leke is the Emeritus Professor of Immunology and Parasitology and Director of the Biotechnology Center at the University of Yaoundé, Cameroon. She serves as Chair of the Board of Directors of the National Medical Research Institute and as Vice President of the Scientific Committee of Cameroon First Ladies Research Center in Yaoundé. Welcome, Professor Leke.
Thank you, BG. Distinguished ladies and gentlemen, my dear friends and colleagues, good evening. I am extraordinarily happy to be with you all here today, and special thanks to the organizers of this 10th ECTMIH for inviting me to present this keynote speech. And it is on the complexities and the future of global health research in developing countries. I want to thank the 4 young scientists and then also Bruno before for the inspiration and really setting the scene for this. It's no surprise that we are meeting here in Belgium. Belgium is one of few nations with a rich history of global health research in developing countries. Interestingly, Belgium is also home to the scientist who co-discovered the Ebola virus, Professor Peter Piot. I'd like to start, though, by talking about another Belgian who's very well known here in Belgium, but maybe a little bit less known to some of us, and talk about his concern for health and his contribution to global health. That's Father Damien, or Saint Damien of Molokai. Father Damien is well known for his work among the exiled lepers on the Hawaiian island of Molokai. Father Damien traveled to the secluded leprosy community of Molokai to tend to the sick and exiled leprosy patients. In his book titled The Spirit of Father Damien, the Belgian historian and journalist Jan de Volder wrote, I quote, "Yet the greatest gift that he, Father Damien, gave to the lepers was to learn to care for one another." Like Father Damien, many individuals, organizations, stakeholders, and countries have been deeply concerned about the health issues faced by developing countries. I often think about health issues like maternal and child health in developing countries from a personal perspective. I count myself blessed to have survived childhood and to now be living beyond the estimated life expectancy age. You see, I just turned 70 last February. But the average life expectancy in my country, Cameroon, is 56 years. So I'm lucky and I'm blessed. And you can see what it is there in Malawi, in Japan, and so on, and make the comparisons. Over the past years, the widely held consensus is that whatever approach is adopted to address health issues in developing countries, it must be backed by a health research agenda. Health research is a key tool to deliver changes and to enable policymakers and practitioners to do more with less resources. A good health research agenda ultimately creates a critical mass of scientists and a solid infrastructure base in developing countries capable of addressing the healthcare issues facing them. It also helps to foster the development of drugs, vaccines, delivery systems, and solutions to broader health issues affecting these countries. Does such a research agenda really truly exist? If yes, is it working? To truly answer these questions, we need to consider the history of global health research in developing countries and revisit some of the models that have been introduced over the years. Before 1960, the focus on health research in developing countries was fundamentally to cater for the well-being and protection of the colonial settlers. From this focus mushroomed several types of research interaction in developing countries. Slide 7. This interaction included parachute research, where the foreign researcher comes to collect samples in a developing country and then returns home to analyze and publish the results, and colonial research, where colonial settlers established a local research institution staffed with expatriates, and the research priorities were defined by the needs of the colonial settlers. These types of health research interaction paid little attention to the local priorities of the countries, was not keen on building research capacity, and did not promote the transfer of technology to these countries. By the 1990s, the health condition in developing countries had worsened considerably. Investment in health research in these countries was at a record low. Remember the 1090 gap? That's a slide that is not on there. The 1090 gap, the growing burden of diseases and the risk of spread to other parts of the world, spurred by the international community to commit to global health research in developing countries. From this commitment arose several initiatives and research interactions with a focus to build a mass of research scientists, build capacity, and conduct research on health issues prevailing in developing countries. Almost 2 decades have passed, so how much progress have we made since then? To truly address this question, one needs to consider recent health challenges, such as the Ebola crisis. From well-documented reports, the first Ebola outbreaks occurred in 1976 in Congo DRC and subsequently in South Sudan, causing about 600 deaths. However, only 40 years after that, during the latest crisis in 2014, were the first Ebola drugs and vaccines evaluated. What took us so long? Certainly, in the past years, there has been so much effort and commitment in promoting global health research in developing countries. However, these efforts must be sustained and revised to better address the challenges of global health research in these countries. So what are these challenges? Please allow me to discuss just a few of them. Some of these were also mentioned in a recently published report by UK Department of International Development. Number 1, research priorities in global health research. Who sets the priorities? We heard a comment of that before. The goal of health research is to deliver change that will positively impact the lives of people. To ensure the greatest impact, it is essential that the research priorities reflect existing and emerging threats. These research priorities could be country-specific or region-specific. As such, regardless of the source of funding, research priorities should be defined at the country level and should include civil societies and communities. I remember myself going into a community to explain to them, this is around in Cameroon, that I would be launching a malaria project in their village. during the discussions, it came up clearly that they could prevent and treat malaria, and they were managing that really well. What bothered them most, they said, was the itching from lower filaria, which maybe some of you have not heard about, which impeded them from concentrating on their farm work. Where was I going to get funding then to help them deal with this disease? I eventually stuck to malaria. On collaborations and partnerships, what model will boost health research in developing countries? Global cooperation is crucial for improving health research outcomes. One such form of cooperation occurs through partnerships. Over the years, the philosophies and attitudes to partnerships building has shifted. Today, both partners in developing and developed countries seek mutual benefits, two-way flow of energies, expertise, and knowledge. However, the challenge is often setting up a partnership model that can produce these qualities. In an article published in the British Medical Journal, Costello and Zumler proposed 4 key checkpoints that could be used to set up a truly cooperative research partnership in developing countries. And these checkpoints are mutual trust and shared decision making, national ownership, ensuring that research programs are owned and managed by nationals with foreign inputs simply technical and advisory. Early planning for the translation of research findings into policy and practice. Development of national research capacity. I and a multidisciplinary team of researchers at the Biotechnology Center of the University of Yaoundé 1 have really benefited from a very fruitful collaboration with Dr. Diane Taylor and her team at Georgetown University and subsequently at the University of Hawaii for over 25 years. The success of our collaboration was truly down to the mutual practice of the 4 checkpoints proposed by Costello and Zumler. Now let's talk about translating research into policy. This has been one of the major drawbacks of health research in developing countries. Most often, research findings or solutions that can have immediate impact on patients' health do not easily get translated into practice. We generally rely on disseminating the findings in peer-reviewed publications, publish or perish, and hope they will be picked up by policymakers. Most often, it does not work that way. For example, evidence supporting the efficacy and safety of anti-malaria drug, the artemisinin-based combination therapies, the ACTs as we know them, was available in the late 90s. In 2001, WHO recommended the use of these drugs. However, the drugs were only made available in most countries after 2005. Also, the unavailability of research results inhibits their translation into policy. Focus should be on promoting interaction among the producers and the users of research, removing the barriers to research use, and tailoring information to different target audiences so that effective interventions are used more widely. Networks at local, regional, and international levels are important in influencing research agendas, research capacity, and uptake of research findings. These networks should undertake research, assist policymakers in interpreting evidence, and introduce new ideas and concepts regarding evidence-based practices. Now let's talk about an enabling environment. Career opportunities and research leadership. Truly, there are no research career opportunities for young researchers once they complete their PhDs in many of these countries. If we want these young scientists to become the research leaders of tomorrow, we really must invest in them. And also the infrastructure and connectivity. Research is often carried out in areas with dismal infrastructure, very poor internet access, constant water and power outages, poor communication, transportation and housing needs, poor quality of data. These issues can only be resolved if research becomes a priority in these countries. Strong partnerships are formed, and extensive bureaucracies and corruption that further exacerbate these challenges are dealt with. Now, the uneven geographic coverage of existing and future research capacity strengthening programs. You see that slide? I really love sharing this picture. At present, geographic coverage of research capacity building activities is very uneven. There is so much focus on Western, Eastern, and Southern Africa, and practically little or nothing outside Anglophone Africa. The landscape of research capacity is weakest in Central Africa. I wrote an article on this in The Lancet in 2010, titled, you can see, The Global Health Governance, the Response to Infectious Diseases. Here, as you can see, are a few excerpts from that article. So we have all these challenges, and what could be a possible way forward? Now, this is what I would suggest. First, we, that means us, we need to recognize, though, and appreciate the tremendous progress that has been made in the past years to promote global health research in developing countries. I must really express our appreciation to funders and to our partners. However, the current challenges necessitate more commitment to ensure global health research in these countries is fit for purpose. This all begins with us now as we debate here, test, and propose new initiatives to promote global health research in these countries. The new initiatives must offer strong and effective mutual partnerships, build capacity for research and training, transfer technology, retain our researchers, and reverse the brain drain, stimulate innovation, and ensure research is conducted on both communicable and non-communicable diseases and on health system strengthening. Second, we, us, the partnerships, need to go beyond this culture of knowledge generation. Much of the research conducted in Africa and by African scientists is on knowledge generation. We need to cultivate a culture of innovation. Innovation not only in the development of drugs or vaccines, but also in designing strategies to finance, to engage, and to deliver health interventions to communities. Innovation is not just about doing things differently, but doing them in a more sustainable and effective manner. Third, we in developing countries need to retain our trained scientists within these countries. It is understandable that our young scientists are attracted to greener pastures in Europe, USA, or Canada. Research has always been a discipline sans frontières. In the past, the migration of scientists from one country to another was coined as the brain drain. These days, there are other buzzwords that are used, such as brain sharing or brain circulation, brain gain. However, in this sharing of scientists, our African countries and other developing countries tend to be on the losing end of the stick. When a scientist emigrates, the wealthier country gains brain power without a comparable asset left behind for the poorer country. Also, we should be able to reach out to the diaspora of developing country scientists, African scientists, and attract them with funding opportunities to securely and sustainably re-enter their countries of origin, so to advance their national research agendas. Fourth, we need to get governments in developing countries to commit to global health research. Our governments need to take ownership of health research agendas in their countries. At present, health research in developing countries is heavily dependent on foreign donors. A difference will be made in meeting health research needs if national governments committed to spending at least 0.01% of GDP on government-funded research devoted to meeting the health needs of their citizens. Can our partners, you all here, can you help us out? Fifth, donor investment for global health research in developing countries should be viewed as a long-term process and be backed by a realistic plan that ensures proper functioning when donor funding phases out. Too many African-based laboratories close out or cease to function when funding from foreign donors or grants run out. For example, ECTMIH2017 ended. Some laboratories closed. We waited long for ECTMIH2. We are glad and grateful it finally came through. And my word to the donors, to the funders, is that 5 years of funding to do a 5-year study is not enough. My humble suggestion, one needs 5 years to do the study and then reduced funding for a minimum of at least 2 years to analyze the results, think about their significance, and disseminate the results to policymakers and peers, and then design the next steps forward. To conclude, I'd like to say that the issues of health research in developing countries are complex, but not unsolvable. We have to keep on working on finding equitable solutions, not simply for today, but to make our tomorrows more rewarding, more fulfilling, and more compelling. If I were to come back to this podium 10 years from now, I hope to report to you that governments in developing countries, especially in Africa that I know more about, are investing in health research as required, that we have an impressive critical mass of research scientists that are actively involved in inserting research agendas with donor support, that South-North and South-South partnerships are fair and well-functioning, that new research initiatives are plenty, that external funding is extended beyond the data collection period with additional time for data analysis and dissemination, that research capacity has been strengthened and is adequate in health research labs in Africa, that connectivity has improved, and that research results are being translated into knowledge used to improve our communities, and that finally, that those previously drained African scientists actually came back to the continent, brought and transferred all the technology that is needed, and have stayed to contribute to improve the health of their communities. May I end here by inviting you all to the MIM conference in Dakar, 15th to 20th April 2018, where we can continue these discussions. And I thank you all for your contributions to enhance global health research in developing countries, particularly in Africa. Please keep it alive. I thank you.